Good morning, everybody. Doing the daily debrief just a little bit early today because there's a new statement that came out just off the presses with the management of lung nodules and lung cancer screening during the COVID-19 pandemic, a chest expert panel review. I'm Dr. Aki Al-Zubaidi, the co-CEO of EHON and also an interventional pulmonologist at National Jewish Health. Let's get started and just dive right in to this consensus document. It's been co-published on JACR in addition to CHEST as well. Let me just start sharing my screen here. Sorry guys for the background noise. Got some got little kids, as everybody can imagine. I think everybody's working from home. But here's the article. This is the journal preproof. But as I said, you can also find this online very easy. Just take management of lung nodules and lung cancer screening during the COVID-19 pandemic. And what this is attempting to do is trying to give some consensus guidance on how you should handle your lung cancer screening program in terms of annuals, in terms of baselines, in terms of lung RADs 1, 2s, 3s, and 4s, in terms of incidental nodules. And so as we go in, obviously the first page is talking about the COVID-19 pandemic, how it's stressed the healthcare past its breaking point, and also, rightfully so, right? Much of the attention has been focused on the immediate needs of patients suffering from the disease. However, when it comes to patients who need to have cancer, but they haven't been diagnosed, here's a statement that's attempting to take us through different scenarios and give guidance on what we should be doing. So let's start with lung cancer screening, baseline, and annual. And so it's talking about an individual who meets eligibility criteria is referred to a lung cancer screening program. And during the COVID pandemic, consistent with the CDC guidance, you can defer non-urgent care. So this is in line with what we've been seeing. However, as you reopen, you need to make decisions on when you actually see these patients and how long you can defer them, right? So, and the way that we've been doing it is that we always look at the patients who have the highest PCA, which is the pretest probability of cancer, first, and then get the other patients in next, right? And so scenario 2 is a patient, and this is for baseline and annual, that you have the ability to defer. Scenario 2 is talking about a patient who has a lung RADS category 1 or 2 on their previous and they're due. And so this again is suggesting that you can delay this during the pandemic. And we need to talk about what that means too. So, and we will. Scenario 3, let me just go back, sorry about that. Here we go. Scenario 3 is a patient's now due for surveillance of the chest with a nodule that's less than 8 millimeters. And so during this pandemic, right, what they're saying is that it's acceptable to delay the surveillance for approximately 3 to 6 months if you have to. And this is, again, taking into a fact that there's a backlog of patients that's just building up. And so it's giving you a time period to say, listen, a patient who is 7 millimeters, if they have a 7 millimeter nodule and they are due for their interval in, let's say, tomorrow, it's okay to wait 3 months if you must, right? But you shouldn't wait 3 months if you don't have to. There's different parts of the country that are hit differently, right? New York, Detroit's been hit differently compared to other parts of the country where the impact hasn't been so great, and you can restart and likely see all of these patients and get rid of the bolus very quickly. But in some parts, they will need to definitely delay that for 3 to 6 months. And then scenario 4 is a lung RADS 3, which is and that's similar guidance as you can expect. To a 6 to 8 or a less than 8 millimeter incidental nodule, where they're saying the same thing, right? 3 months and you can wait. And they're giving you that the probability of a lung RADS 3 actually having cancer is 1 to 2%. So 2 people out of 100 need to be diagnosed with lung cancer out of that group of lung RADS 3s. And so what we've seen is that the majority of people have around the country are seeing lung RADS 3s now and not deferring 3 months because they do have the availability to get the 4s and the other patients in currently. And as you start to ramp up over the next 3 weeks too, we suggest that 3s and higher, along with anything greater than 8, is being seen if you can. But if you need to tear it out, obviously this is a good document to tell you how to tear that out. Situation 5 is a patient's now due for surveillance CT and incidental detected nodule. It's a pure ground glass nodule, right? And this is just saying that you can defer non-urgent care for about 3 to 6 months. And, ground glass nodules, they have a different doubling time if it is cancer. In addition, AIS normally presents as a ground glass nodule, sometimes can have solid components to it as well. But in terms of the ability to, cause an upstage or a potential metastatic spread for a ground glass lesion is less than other lesions. And so they're just saying that you can wait 3 to 6 months on that. And then in terms of the intermediate or high risk nodules, right, like lung RADS 4 or higher, or an incidental nodule that's greater than 8, here, what they're saying is that the estimated probability of that patient population is anywhere from 10 to 25%. So let's take that and say that 25% of your patients, 25 out of 100 patients, are going to have cancer in this group. And so, what we've been doing is that, listen, if 25 people need a lung cancer diagnosis now, we've been getting those in, right, and getting them their scans. But if you are in an area that is extremely affected by the COVID pandemic and with CDC guidance to defer non-urgent care, you can evaluate that patient in 3 to 6 months. Now, as we know, a lot of the guidance here in Colorado, all non-essential procedures have been halted until April 26th. That's Monday, right? So it's there in terms of the guidance, both locally and from CDC. As you have the ability to start seeing these patients that are at a higher risk need to be seen first. And this is what Safety Net does, right? Safety Net is going to put these patients that have a higher risk of cancer up at the top of your list to be able to see them first. And so as we continue to go down, scenario 8 is a lung RADS 4 category, like we said, 10 to 25%. And then now, if you do have a incidental nodule that's greater than 8 with a pretest probability of 65 to 80%. Here, what they're saying is that it's acceptable to do a PET scan, and if the PET scan is positive, that you go to stereotactic radiotherapy or surgical resection. So this is, if you look back at the 2013 guidelines of what is put out by ACCP, is that you should be doing a pretest probability on your cancer, on your nodules. And if the pretest probability is greater than 65%, you used to be able to just go to surgical consultation. And now the difference is that they're suggesting to do a PET, because if you have a PET and it's positive, then you increase the post-test probability, and you're not going to be sending patients with unlikely cancer to a surgical consultation or to SBRT. And so that's important to know, right? And if it's PET's negative, though, right, remember, because the pretest probability is 65 to 85%, this is still a patient that you should not then go back to CT surveillance, right? This is a patient who still will need to have some sort of tissue acquisition at some point to determine whether or not it's cancer or not. And then scenario 12 is talking about a patient who had actually been diagnosed with clinical stage 1 non-small cell cancer. And then this is talking about the treatment of a clinical stage 1 may be delayed in conjunction with CDC guidance. And consideration has to be put into the size of the cancer, the growth rate, and PET avidity. This is something where, and they're talking about discussed at a multidisciplinary tumor board if available. And the surgical body also had some guidance about saying that if the size is greater than 2 centimeters, then definitely go for a surgical consultation and probable resection. But this is saying that if you were in an area that must be pushed off, that this is a patient that you might be able to push off. So what's interesting is that table 3 is something that I really leaned on here. And this shows you all those 12 different scenarios and how the members of this group actually voted on each different scenario and what the recommendations were. So as you can see at the top, delay of the initial screening, delay of the annual screening, I think everybody is in conjunction with. And then if you look at the bottom in the middle, right, consider delay in treatment for stage 1. Everybody agreed. Avoid further diagnostic testing of a solid nodule with a post-test probability of 85%. Evaluate solid nodules greater than 8 with a PET scan. There was a little bit of disagreement there, 79%. And so what we're saying is that if we were to take, in safety net, what we do is that we take 12 to 1, right? And we list your patients from 12 to 1 in that order, so that when you do restart, that you actually start with those scenario 12, you knock them out, you get them all seen. Scenario 11, scenario 10, scenario 9, scenario 8, scenario 7, and then you get back to initiation of screening, right? So the way you ramp up your service line is through safety net, right? And it's in conjunction with what the guidance is from ACCP and JACR, where it's telling you that, hey, listen, high risk patients, they need to get a PET scan, right? Patients if you're in an area where PPE is an issue and they need it for the COVID response, and starting up your clinic or having these patients come into your radiology department is consuming PPE or other issues that you have with supplies for taking care of your COVID population, then you can delay these, but you can only delay them 3 to 6 months in terms of, the intermediate probability patients is what this is saying, right? So that time period is going to come quick, right? And so what we do in safety net is that we have the patients who are all due, and the time period from when they were expected past that time. And then we put those first, so that not only are you seeing 12 to 1, but you're seeing the folks that are going to reach that 3 to 6 month milestone before they actually get there. And so that you can be in conjunction with what everybody else is saying is best to handle the bolus of patients that need to be seen because of the deferment of non-essential procedures due to the COVID pandemic. So, what I'll say is this, is that we have to start seeing patients now, if it's possible, right? And it's going to be possible for many of us to start seeing patients over the next, I think starting in the next 3 weeks. A lot of hospitals are starting to ramp up their service lines. If you're in an area where you can't start your service line, obviously we understand. But the reason that we're donating safety net is for this reason, right? Is that there is a lot of confusion about who to see, right? And you may want to just start up seeing your baseline scans, and I got to get my lung cancer screening program up and going. But you need to see all these incidentals that have a high pretest probability. You got to see your 4Xs. You got to see your 4Bs, right? You got to see your 4As. You got to see folks who are 3 months out versus 1 month out, right? If you have a 4B that needs a PET scan, right? And that person had their 4B scan 3 months ago versus 1 month ago. You want to organize this in a manner that makes sense, right? Because there's a pretest probability that says, okay, 25 out of 100 are going to have cancer. Cool. All right. Well, I need to find those 25 and diagnose those first versus the 1 out of 100, right? So if I get in those 100 patients, I'm going to diagnose 25 patients with cancer. However, there's also the time clock for upstage, where those 25 people who have cancer, the longer they wait, there's a chance of progression or upstage, right? If I'm going to be upstage with cancer, and my cancer is growing or possibly going to other parts of my body, I want to make sure that I'm seen sooner, right? So what we're doing is we're saying that, okay, cool. You had your scan, over here, right? And then somebody else had their scan over here. I want to see the one that had their scan first, as opposed to the one that just had their scan and they're at risk, right? And then once I knock this one off, look, this is what I need to do. I need to see this patient next, and next patient, and next patient, and next patient. We help you organize your patients in order of who needs to be seen first. And, I think that, just bring up this one last second before we log off today. And we're going to be going over that article a little bit more next week. But listen, you can get this for free. Safety Net does exactly what this paper is telling you to do. And, you know, it's a top-notch, state-of-the-art, best-in-class computational linguistic platform that's going to be able to not only identify these patients, but then also segment them into the risk categories that you need to see these patients. So, you know, looking forward to next week and the task force on essential patients. Can't stop yelling it, right? Can't stop talking about it. Like every service line, not just lung nodules, right? You need to see the patients that are most at risk for whatever abnormality that they have, right? And segment them and knock those out effectively, efficiently, and get rid of the bolus so that patients aren't harmed. They don't have an increase in morbidity and mortality because of delays in treatment, or you start, you know, your baseline screens before you see your 4Xs. You do your baseline screens before you do, you know, a 1.2 centimeter growing spiculated nodule in the right upper lobe, right? Like you gotta see those patients first. You gotta have awareness of them. So that's what this is all about. That's what we've been doing for the past, you know, 2 months, night and day. You know, it's been yelling from the rooftops that, hey, there's this bolus of patients that are there that you need to see in this order. So I'm really happy this paper has come out. I'm going to talk about it a lot more over the next week, and looking forward to catching up with everybody on Monday. New information coming by the minute. We're going to be continually pushing that out to you guys. If you have any questions, please send your questions to at the eonhealth.com website for the webinar. We're going to be answering them with a group of experts. Looking forward to talking to you guys then as well. Bye-bye.